Hello, everyone. Welcome. Thank you for coming along today to our very first HSMA showcase session. So the idea of these little sort of bite-sized showcases, we've got a few lined up over the next 6 months. And the idea is to give you a bit of exposure to what the rest of the team are doing in terms of the research work, both current research work and stuff that we've done in the past. Two reasons. First of all, so you're a bit more aware of the work that we do within the PenCHORD team, because it's not just about HSMA. It's obviously HSMA is obviously an important part of it, but we are a research team that's been going since the end of 2010, beginning of 2011. So we've got lots of experience working collaboratively with health and social care services to develop simulation models and data science solutions to try and resolve some of the problems. But the second reason, particularly important for HSMA, is over the coming months, you're going to be thinking about what projects you may take forward into phase 2 and coming up with ideas and project proposals. And so we thought it would be useful to just give you a few showcase sessions over these coming months, so you get a bit of a taste of the stuff that we've done in terms of turning the kind of the more abstract stuff that we've covered so far in the training, and obviously we'll soon get into the method stuff, talking about the various discrete event simulation and agent-based simulation, machine learning, all that kind of stuff that you're going to learn about soon, but showing you some real-world applications for this that have happened. So hopefully this will help spark some ideas in your own minds about potential sort of projects you could pursue and the potential for this kind of stuff in the real world. So we've got a number of these lined up. A couple I'll be doing. My colleague Tom's going to be doing a couple. We've got Mike, Kerry, and Anna, who are going to be talking about the fantastic stroke work that's been going on for over a decade, particularly around machine learning and geographic modelling. And Elliot's also going to be talking about some of the work that he did in his MSc project before joining us. So there's lots of different stuff that we've got lined up for you. We'll record all these sessions as well, so you can refer back to them. They'll go up on our YouTube channel. So let me start sharing. So today I'm going to be talking to you about a project that I did a couple of years ago now. So back in 2020, at around the start of the COVID-19 pandemic, and we were actually approached by an alumnus of the HSMA program, someone from HSMA 2, whose partner worked in palliative care, and they were starting to get some real issues, as you can probably imagine, and they wondered if modelling solutions might be able to help them. So he sort of put us in touch, and we worked with a team up in Bristol in order to try and see if we could help out a little bit. So let me talk a little bit about the problem, the background to it. I should also say that this was a pretty rapid project that was done in the sort of panic stages of initial pandemic. So I will show you the model today. It's not a particularly elegant model, and I'll give you the link where you can look through it. It's not brilliant at all. It doesn't run particularly efficiently, but it was sort of knocked up in a few weeks in response to a need that they had. So end-of-life care is particularly vital to ensure that people who are at the end of their life are suffering the least amount of pain and discomfort and distress as possible. And it's something that kind of got overlooked, kind of understandably, at the start of the pandemic, because all of the focus went on treating people who were coming into hospital and trying to prevent public health measures to try and prevent the spread of the disease. But unfortunately, it's the case that with certainly pre-vaccine, we were in a situation where COVID was killing a lot of people, and there was only so much that could be done. There was no cure for it, and it still isn't. And so it's an unfortunate reality that for some people that got COVID, they were going to die. And so it was a little bit overlooked in terms of maybe we should also be thinking about making sure that end-of-life care is properly resourced, so that at the very least people who are unfortunately passing away as a result of this, their sort of final moments are as comfortable as possible. Now, the average duration, certainly at the time, for end-of-life care for COVID was pretty short. It was, people were dying pretty quickly of this. But which you may think, well, is it therefore a resource problem? But it is, because you have a global pandemic with a large number of people, particularly the kind of people that were typically dying from this, having quite complex needs and requiring end-of-life care all at the same time. And a massive surge in demand for end-of-life care, coupled with already strained resourcing. So one way we can think about the resourcing for end-of-life care is to think about it in two groups, which we call stuff and staff. So there's various stuff resource that we think about in terms of end-of-life care. That's things like bundles of anticipatory medicines, to things that would ease pain, discomfort, distress, so trying to minimize breathing difficulties, pain, etc. Also syringe drivers or pumps to administer some of that medication, depending on the severity and the needs of the individual patients. And then you've got the staff resourcing you have to think about. So district nurses playing a huge role in end-of-life care, providing that medical care, arranging equipment, the other stuff resources, coordinating packages of care in multidisciplinary teams. Care assistants, again, playing a hugely important role, providing that personal level care during the day, and also night sits, where they stay overnight in service users' homes, particularly for more severe and complex cases where they need sort of 24-hour care. Also specialist palliative care, so typically that might be support from a local hospice. That might include things like physical visits, or in some cases maybe just calls to check in on the patient. Also, depending on where the patient is experiencing their end of life, if they're in the hospital, we have hospital nurses who are typically fulfilling a lot of the duties of district nurses in the community setting. And so there's the hospital nurses to think about, and also GPs who play a vital role in all of this as well, in terms of making assessments, prescribing various medications, and liaising with these other people as well. So in our model, and you'll see it a bit more in a moment, we captured hospital end of life stay, but from the perspective of stuff rather than staff, because the particular people we're working with didn't really have the control over the hospital resourcing. And so we looked, but obviously they'd still be needing bundles of medicine, and the syringe drivers, that would still need to be taken into account. And the model we set up so that you could put all that stuff into the hospital end-of-life care as well. And we also had to exclude GP resourcing, primarily, unfortunately, because the data just wasn't there to support it. And that was a real sort of black hole in our model, that we made very clear. So we could only report on the kind of non-GP staff resourcing that would be needed. So that was something, and remember when we talked about at the very first session of HSMA about making sure that results are understood in context, we were very clear that there would be significant increased burden on GPs because of this, but we weren't able to quantify that. Okay, so what were the aims of the project? There were two kind of key aims, really. The first was to pretty rapidly develop and then publish a free and open source FOSS generic model of stuff and staff resourcing for end-of-life COVID-19 patients. we, from the very start, we wanted to make sure this was a FOSS model. This was something that could be used by other people, because we were working with Bristol, North Somerset, and South Gloucestershire, but clearly this is not an issue that was constrained to them, and we wanted to make sure that other people across the country and across the world would be able to access this and develop up from it as well. So that was a key objective, but then also to use the model that we developed in order to plug in the data from Bristol, North Somerset, and South Gloucestershire to try and generate some predictions about what the additional resource need would likely be, based around the spring 2020 peak, as it was back then. So that was the time we did the project, which was around sort of just after spring, coming into summer 2020. The peak that we'd experienced was around the spring peak, not long after the outset of the pandemic. So it was based on, if we get another peak like that, another surge, what would you need in order to be able to cope with that in terms of end-of-life care resourcing? So broadly speaking, the way the model works is it captures this stuff and staff resourcing, and it captures the fact that end-of-life care will be taking place in different care settings. So some people will be at home. In fact, I mean, we heard stories right at the start that paramedics were turning up and saying, having awful conversations with patients, but saying, "I'm really sorry, but you are likely to die, and do you really want to go into hospital?" And actually, a lot of people were just choosing to stay at home, and that was quite a big thing. Obviously, because of the nature of COVID affecting particularly people who are more vulnerable, complex needs, a lot of people in care homes, both in terms of residential homes and nursing homes, and we model those slightly separately, because they had slight differences in terms of the kind of resourcing they would need, and also, as I say, people in hospital, but that was just in terms of the staff resourcing that we did for this particular application of the model. And then for each of those settings, essentially a patient would receive a bundle of care, which would be a bundle of resourcing of stuff and staff, and some sort of frequency. So you might have some patients that would be getting a district nurse for 1 hour twice a day. Other patients might get but they might also get 2 care assistants for 40 minutes a day, 4 times a day, as well as 1 hour specialist palliative care per day. Then you might have patients who need more than that, so you get more frequent district nurse visits. Maybe they need syringe pumps, etc., etc. So there were various, and the way in which we did this was to essentially categorize in consultation with the commissioners. We were able to sort of categorize different cohorts of people and their likely needs. So sort of people that have very high needs would need a particular package of care compared to someone that didn't. We built this as an infinite capacity model. We talked a little bit about that in the very first HSMA session. Remember, that's essentially where we model something that's unrealistic. We say that there is infinite capacity, but that in itself can be quite useful because it tells us what capacity we need. We're not constrained by the real world. It says, in an ideal world, what resourcing would you need to meet this level of incoming demand, which is essentially the question we've been asked. So essentially, each patient went down one of these streams. They were either in home, a nursing home, a residential home, or in hospital, and they would be assigned a bundle of care, and that would continue for the duration of their end of life until they die. So it was a fairly simple structural model in terms of there's basically 3 sets of activities. They go into that activity for an amount of time, consume an amount of resource, and then leave the model because they've died. But a lot of the detail came in terms of those bundles of packages and what that meant in terms of daily needs. So where do we get the data from? As you could imagine, at the start of the pandemic, this was tricky. So we had some data. There were some studies that we could draw on. A lot of it was expert opinion that we were going on, people that were working on the coalface and also speaking to the commissioners, and getting a sense about the kind of level of need that different patients would require in terms of their resourcing, and trying to work things out from that. So we had some data to populate our sort of incoming rate of activity from a Scottish study that combined with some ONS data that we had and some government statistics to try and work out the proportion of people needing end-of-life care in different settings. For duration data, there was a study, a London study, that looked at the hospital duration, so we could estimate based on that was a pretty good study that allowed us to be quite accurate with those predictions. But for community care, where people are dying in their own home or in care homes and etc., we were reliant on expert opinion about what that would look like. And the bundles of resources, say, was in consultation with the people that were actually doing this and the commissioners. And this is essentially the table that we came up with in consultation with them. So we can see there's different bundles depending on where they are and the kind of level of resource need. You might be thinking, why would you have someone who's dying who has low needs? There's various reasons for that, but a key reason very often is that some people just choose that they don't want that level of intervention. They know they're dying and they kind of want to die in peace, and they just want the minimum required to sort of minimize their pain and discomfort. And so a lot of people choose to do that as well. That kind of split. Other people will have very complex needs, having quite an unpleasant end-of-life experience, and need and choose to have that level of intensive care. So you can see various splits. So here, for example, somebody's in their own home with a very high level of need, which was estimated to be about a quarter of the patients at the time who were at home for their end-of-life care. Looking at 2 visits per day, 2 1-hour visits per day from a district nurse, with a bit of variability around that as well, to account for travel times and the fact that things may overrun with other patients, etc. Some 2 care assistants, 4 visits a day, 40 minutes a time, bit of variability around that. A night sick care assistant, 12 hours a night every other day. Looking at an hour a day of specialist palliative care intervention. Anticipatory medicine bundles for the duration of their end-of-life care, and a syringe pump, compared to someone, for example, who's at home but either has lower needs or chooses to have less intervention, may only get a district nurse every other day for half an hour and maybe some anticipatory medicine, and that would be it. So there were different ways in which we could structure that, and we had these estimates of the percentage of people that were essentially funneled down each route. And you can see as well in here, we were just modeling for hospital, essentially these stuff resources. Okay, so let me show you the model. So I put a link here, and I'll put the link up in Slack as well, so you can follow. I did this is actually included in one of the earlier sessions. One of the things I got you to have a look at in the 2A session, where we looked at Spider and Jupyter and Colab, was this model. So you may have already seen it, and you may already have the link, but I'll pop it up again in case you don't. But this is basically the model, and as I say, this is built in SymPy, so you can you'll be able to build this kind of model very soon in the course. So I won't go through all the details, but basically you can set up various aspects of the model. So we put this up on Colab, and people can run the model and change the model, either by just changing the parameterization of the model, or even, because it's free and open source, people can take this model and adapt it for their own particular needs as well. So you can set up how many runs of the model that you have, the frequency with which they're going down sort of various different streams. Some of this stuff that we didn't include, because this is an infinite capacity model essentially, so we didn't constrain the capacity, but the model is set up. If you want to constrain the capacity, you can actually do that. Inter-arrival times into the various different streams of care, how long people are spending at home, etc., etc. and set up all of these different things. And you can run these things, and it explains basically for each cell, this is what this bit of code is doing, and this is how you need to change it. So even if you're not a coder, you can go in and it'll tell you what you need to change to run the model for your own needs. And then basically you get down to the bulk of the model, which sets up all of these packages that I've kind of described in that table, and then runs the model down here. And as I say, it's certainly not elegant. This was designed and built very, very quickly. There's about 3 weeks between us being approached for the project and getting all the data together and talking to all the stakeholders and actually building the model. We just rapidly got something up and out with the idea that, they needed information quickly. So this absolutely would benefit from a bit of streamlining. So whatever you do, don't look at this model and think that's a model answer for how you write a discrete event simulation, because it's not. Absolutely not. It's not even object oriented for a start, and it's very procedural, and it's a bit inelegant, and it takes quite a while to run, but it does the job. Which is what we needed it for. Basically, as well, we'll talk a little bit about this when we get to the SymPy training, but it uses what we call containers as the resource, where rather than thinking about resources as being you've got a nurse and you've got a doctor and you've got a bed, that kind of thing, this actually thinks about things in terms of being containers. So we thought about it in terms of for the staff resourcing, the amount of time. So we'd look at how much time district nurse time is being consumed, how much care assistant time is being consumed for that kind of staff resourcing stuff. And containers allow you to do that kind of thing, and you'll see that in the course. And that was kind of more useful for them than trying to work out. So it was less about a sort of queuing model here, because nobody's really queuing, because for starts, it's an infinite capacity model. There is no queue, but it's about how much resource is being drawn in over time, essentially. So that's the model, and I'll let you check that out in your own time. But say, forgive me for its inelegance, and give it a while to run. If you do run it, I think it defaults to 2 runs of the simulation. I wouldn't go beyond that unless you're patient. But we got out some initial results, and based on the data that we had for their particular population, and the consultations that we made with their experts, it basically predicted that if they had another peak like the mid-April 2020 peak, which of course we now know in retrospect was not the peak of the pandemic, and in fact things got a lot worse thereafter, but even based on that initial peak that we observed, they were predicted to need just for COVID-19 end of life care. This isn't predicting anything else. They'd need an additional 12 hours of district nurse time per day, about 9 hours of care assistant time per day, another 6 hours of care assistant night sits per day, about another 9 hours of local hospice support per day, 10 new bundles of anticipatory medicine per day. Already they were struggling with the supply for that, and an additional 9 syringe pumps being in use per day. These were significant increases, hugely significant. I mean, they were worried when we showed them these results, because they could see that. I mean, it kind of matched what they were expecting, because they were starting to see this. But sort of seeing it in black and white and seeing the level of additional resourcing that they would need per day in a sector that was already struggling was quite stark. So these are significant additional resourcing, and obviously it got much worse as well, unfortunately. And there was an additional problem, because of course our model worked as a predictor of excess resource need, assuming that the pandemic, the kind of baseline level of non-COVID end of life care was unchanged. But obviously we got the suspicion then, and we know now in retrospect that wasn't the case, that actually because of the pandemic and because of the response to it and because of things that needed to happen, there were also other non-COVID deaths that happened, and so that would have increased the need for end-of-life care as well. So we were always very clear that our results would likely underestimate the actual excess end-of-life care resourcing need as a result of the COVID-19 pandemic. But that was the whole reason for us making this free and open source, so that others could plug in new data as it became available. They could use the model for their own purposes, and put in their own parameterization, and even adapt it as well. And so it gave them this model. Essentially, the impact was that it gave them the tools in order to be able to recognize exactly the kind of resourcing level they need. And it was really useful for the commissioners because they were able to hopefully better respond to what they were seeing. They knew they had a problem, and this kind of helped to quantify the extent of that problem, so they could put in measures to try and kind of rejig things as best they could to meet that level of demand. Okay, I will stop there and open up if there are any questions. Please do shout if I don't. I'm scrolling through. I don't always see the hands up as well, so do shout if not. No, can't see anything.
Hello.
Hello.
Hi. I was just wondering, how did your predictions actually compare to the results that they saw? You said that your assumptions underlined that it was going to probably be an underestimate.
Yeah.
Is that what played out?
The answer is we don't know. We don't know. So we got pulled off to do other work, and we were hoping to basically carry on and continue actually to do a bit more work in this sphere, and actually to look at what happened sort of post model, but that never happened, unfortunately, in the end. So yeah, we don't know. I think it would be really good to look back, particularly now, to see how that did compare with the reality, because it's clear. I mean, the April 2020 peak was nothing compared to what happened later that year in particular.
No, indeed. Thank you.
Yeah, there was a hand up, I think. Sorry.
Mine maybe. Hi Dan. Really interesting. I saw that you used, for the prevalence, you used Scottish numbers. Did you not worry that the numbers in Scotland would be very different because they handled everything very differently to England? So you used duration, exactly. So you used duration from London, but then incoming activity from Scotland.
Yeah.
And those two things could be very, very different.
Absolutely, and that was a key limitation of the model, and something that we flagged up. And in fact, I'll put a link to the paper as well, so that you can read the paper online. We talk about that, about the fact that this is potentially problematic. We were literally at the time scrambling to find anything, and this was for the what we needed for the model. This was the best we had. So obviously, now we could get much better data that would enable us to parameterize this. But yeah, at the time it was so new that we were basically scrapping, grabbing whatever we could. So I think we did do a bit of sort of sensitivity analysis around it as well, and said, what if these estimates are out? How much does that change things? So but we were very clear that this might be, a lot of this was guesswork that we were having to plug in, and some of it, I think a lot of the bundle stuff was actually quite accurate, because it reflected what they were seeing on the ground. But yeah, it was best guess. So yeah, it'd be really interesting actually to with the wealth of data that came out after, to kind of go back to this and see what, how it would look now, I think.
So was the model successful despite those limitations? I mean, was it quite accurate in predicting how much resource you?
So that, I mean, that ties into the previous question, really. We don't know the accuracy. What we do know is that it allowed them to be able to better prepare, and to I think it was kind of the order of magnitude of increase in resourcing that they would need. That's what, essentially, by bringing the commissioners into this project, that gave them the power to be able to say, right, we need to chuck additional resourcing into this because the system is not going to cope based on the level, the current resourcing level we've got. We're going to have a problem. So it was, the main output was really, this isn't, you've got quite a significant problem. It's not just a small, you need quite a significant additional amount of resource. And so that's essentially, the commissioners used that. They were running a sort of simple Excel based model to try and predict this, and they basically used these numbers instead to then plan forward.
That's fantastic. Thank you.
No problem. Yeah, some more. Sorry, it just says 2 hands up, so I'm just scrolling through to find where they are. So please shout, because I'm struggling to see where they are.
I don't know whether I am first or not. Just a technical question. I didn't probably mention, but I didn't hear. Does the model allows for migration between the bundles, or it does? Okay.
Well, so yes and no. So it's a good question. So originally, yeah, that was the plan. It was going to be that we would set it up so that recognizing that there may be people that start their end of life care at home, but then because of changing needs, then need to either go into hospital or into a care home, or the other way around, that people who were dying in hospital were then going out into a community setting. So we didn't for applying this model for the Bristol data, because we didn't have the data for it, but we did build that into the model, so you can actually switch on that functionality, and it will allow you, it's somewhere at the top, it allows you to then have that where you can have people switching between different paths of care. So yeah, we accounted for it, so people can, if they've got the data for it, they can plug that in.
Okay, thanks.
I can't see any other hands up, but if there are any other questions. No? Great. Okay, well, thank you. I hope you've enjoyed that today. I'll post the links to this as well. I'll also dig out the link to the paper, so you can have a read of that. We made that the paper, so the paper actually got into BMJ Open, so you can, the paper's free and open source, and you can read that. You don't need a subscription or anything. You can find out a bit more about that project. So do have a read if that's something of interest. It's I think my key message for this would be that this is a highly important and often overlooked area, and especially with something like a pandemic, where you can understandably people will immediately go to try and focus on saving people's lives, but there's also an aspect where you have to acknowledge that some people will not be saved whatever you do, and it's also about making sure that their end of life experience is as good as possible. So it's an interesting area, and it's certainly something that I know that the partners that we worked with in Bristol are keen to explore further. So if people want to do anything around end of life care for their projects, I'd be very happy to link you up with those people who are keen to do more in that sphere as well. Brilliant. Okay, we'll stop there. I'll post the links, and thank you for coming today, and I will see you on Tuesday for the next training. Cheers, everyone.
Thanks, Dan.
Thanks, Dan.